So, afternoon, everybody. Welcome to the asthma updates for schools for the North East North Cumbria region. My name's Laura Cassidy. I am the Network Delivery Manager for the Child Health and Wellbeing Network and have responsibility for the Children and Young People's Transformation Asthma Programme workstream at this moment. I'm just going to do a little bit of an introduction to the Child Health and Wellbeing Network, and then I'm going to hand you over to our asthma leadership team colleagues, who I will let introduce themselves, and they will be leading the session. So, as I mentioned, this has been delivered by the Asthma Leadership Group for the North East North Cumbria Integrated Care Board. I'm Laura Cassidy, Network Delivery Manager for the Child Health and Wellbeing Network, and we've also got Dr Neelmarnee Ramphul, who is our clinical lead for the asthma workstream. We've got Carol Barwick and Clare Caygill, who are our community asthma advisors, but I will let them give a bit more of an introduction themselves. From a Child Health and Wellbeing Network perspective, we have responsibility to deliver the Children and Young People's Transformation Programme, which is part of the NHS long-term plan, which long-term conditions sits within and the asthma workstream. And it's very much about improving management and care of children and young people with asthma and service improvement, but looking at how we can do that from a broader community perspective. And obviously engaging with school settings is part of that. Could I just ask people to make sure their microphones are on mute, please, because we are getting a little bit of background, I think, in people's offices as well. So just to give a bit of a priority from a network perspective, you can see there we have our priority wheel, and sorry, there's just a lot of feedback. Could we ask everybody to go on mute? Sorry, I've just managed to mute everybody, but if we can just be mindful of that, because obviously I don't want any confidential conversations also kind of being heard over the session as well, with it being in a school setting. You can see there we've got our 10 priorities, and the asthma workstream sits within that around those childhood illnesses, but also the wider things that we do around inequalities, access, additional needs and vulnerabilities, strong start in life. But pivotal that is children and young people's voice sat within the middle of that. And as a result of COVID, we went back out to the system, and actually family support was also part of that wider ask to the network. You can see there that we do a lot of work from by working in partnership and doing that cross-cutting through basically work in a play space. We've just done a recent pilot where working at that neighbourhood level and looking at the broader impact that we could have working from an asthma perspective. So this just gives a bit of the context to the work and a lot of the work that the team do, and they'll go into obviously the work around the asthma from a community perspective and from an education setting. So I'm going to hand over to the asthma team, who will give you the full session and delivery of that.
Next slide, please. Hi, so welcome to everybody. This is an exciting opportunity for us to talk to you all. I can see some people on our attendees today that we've worked with in schools, which is really lovely to see you. So welcome everyone. The idea that we will present some information to you in slides for about 30 to 35 minutes of this afternoon, and then give the opportunity for questions at the end. If anybody does have a question that they want to ask at the time of the presentation, please put it into the chat, and then somebody will try to answer that the best they can. We will also give an opportunity for an email that will be added to the chat. So if there's any questions following this webinar, or anytime you want to get in contact with us regarding any of the aspects of the presentation, please do so, and we'll be happy to speak to you or answer any of your queries. The purpose of the webinar really is to offer an update on the recent changes in asthma management, and to ensure schools are empowered to support their children and young people in school who have asthma. It's not classified as training session or a qualification, but we will signpost you to those opportunities during the presentation. So then, what's all this about? Asthma is a really common and chronic condition. It's a medical condition in children and young people. However, it can affect you at any part of your life. There's around 1 in 11 children live with asthma. The outcomes for children and young people living in deprived areas are much worse than those who don't. and the UK has one of the highest emergency admission rates for asthma in Europe. There are very high numbers of children being admitted to hospital each year. And unfortunately, asthma is a main contributor to school days lost. The sad part about these statistics, and the catastrophic statistics, is in actual fact a child dies every 4 weeks in the UK from asthma. So it's a very serious condition. And unfortunately, when a condition is known as a common and chronic condition, it's often not classified as a serious condition, and we need people to know this. Next slide, please. The statistics, therefore, what does this mean? If we've got 1 in 11 children who's got asthma, what does this mean for us in school? Well, it means on average there's 3 young people per class. Now, this can vary from region to region and per area, but in the northeast in North Cumbria, we do have at least 3 children per class. The statistics for admission fell considerably during the pandemic, but are seen to be recovering now quite rapidly, and we're having a lot of children getting admitted to hospital, and this is very concerning. So what can we do to work together on this? Next slide, please. So let's first of all talk about asthma. I am a specialist nurse working in a James Cook Hospital, and I'm also a community asthma advisor. So I work a lot with children who have asthma, children and young people we call them, because after the age of 12 they are young people. So what is asthma all about then? Why are we so concerned? It's a common and chronic condition that affects breathing. It can be complex and it can be very serious, and there's lots of factors that affect the condition. It's linked strongly to genetic and environmental factors. Children often have other conditions that are linked to their asthma, other allergic conditions, such as rhinitis, commonly known as hay fever. That condition can also be year-round as well. They may have eczema or food allergies, and the most important thing about knowing about children with allergies and allergic conditions, particularly those with anaphylaxis, they're at a much, much higher risk of severe exacerbation than those who don't. Asthma can affect people of all ages, but it often starts in childhood. But it can also develop at any time, and it can be the first time you have symptoms can actually be in your adult years. Several conditions can cause these similar symptoms in children, which common statistics for asthma is showing that a child who is displaying signs of respiratory problems may not get their diagnosis for up to 3 to 4 years following these symptoms. And it's important we appreciate and realise which children are displaying signs of symptoms earlier, so that the treatment can be more effective and less damage is done to the lungs the sooner that the child is treated. Next slide, please. So a little bit more about the condition. This slide shows the difference between healthy airways and asthmatic airways. There are 2 lungs, and there's a main airway running down the middle of those lungs, and it splits into 2, supplying each of the right and left lungs. Asthma happens in the smallest of these airways, and you can see on the left-hand side of the slide what a healthy and normal airway looks like. It's maintained by smooth muscle, and it has a large diameter through the middle. Although these airways are magnified here, they are very small to begin with. It's almost like on the left-hand side, it demonstrates the ability or the feeling that you can breathe through a hose pipe. And on the right-hand side, the tightness of these airways following an asthma exacerbation shows that the muscle has gone very tight, the airway becomes twisted, and the lining of the airway becomes hot, swollen and inflamed. So the difference between the left-hand side, that you can feel you can breathe through a hose pipe, and the right-hand side for the child, it feels like they can breathe through a drinking straw. The difference in these children would be that they might develop symptoms such as cough, breathlessness and wheeze. Not all children have all of these symptoms together, but most of these children have these symptoms at some point. It's understood, or it's commonly misunderstood, that all children who have asthma will wheeze, and they don't always wheeze. That some children only get wheezy when this asthma is severely affected. All children have different signs and symptoms of asthma, but commonly there are ones that we can look out for, which tell us when asthma is becoming a problem. Next slide, please. So, triggers. What are triggers? Triggers are things that make asthma worse. There are hundreds of different triggers that can affect asthma. No two children are the same. There are some common triggers that children will say that they have, and they could be in common with other children, say particularly in an asthma clinic. But every child will have their own individual triggers as well. And it's important that families share with schools and organisations what their child's triggers are, so that we're aware how we can reduce those triggers and avoid exposure. Particularly those the child might be exposed to in school. For example, when the grass gets cut and children go out to play on the grass, or when school's been painted during the summer holidays. And one particular one is exercise. There's an awful lot of children, when their asthma is poorly controlled, have difficulty on activity and with cold weather and exposure to, say, wind, etc. So it's really important that there's a good, effective communication from families to school, so that schools know what to be aware of. You can see these are split a little bit into different groups in terms of inflammatory factors and irritants. So some children might be allergic to furry animals, or animal skin is the most common one. Respiratory infections, when children have infections in the winter, it can make their asthma a lot worse. It might be things like temperature change, going from a nice warm classroom to a cold playground. Exercise, as I've already mentioned. Some children have problems with medication. The ibuprofen, particularly in children with asthma, can cause an exacerbation of their symptoms. And pollutants. So it's to be aware of children's triggers and how we can reduce those in the environments that children are attending. Next slide, please. So what's our aims and objectives for these children? Well, we want children to be able to do everything that other children can do, even if they do have asthma. The aim is to reduce their weekly symptoms, reduce their need to have oral steroids and lots of medications. We want to make sure that children are taking their treatment at the right time and taking it regularly. We're asked as physicians to consider that most of the time, children probably take the treatment about 50% of the time. And certainly in school holidays, concordance with treatment drops considerably. And for this purpose, we have a September surge. And this is a result of children not taking their treatment, well, partly due to the children not taking their treatment correctly in the summer holidays, amongst other things. We want to encourage them to have a good technique with their inhaler, and we want to empower families and young people to self-monitor and self-medicate. Knowing what good control is by everyone will prompt early recognition of symptoms and allow us to intervene if needed. Self-management is encouraged. However, guidance by other professionals and teachers, for example, can reinforce the key messages and support a child or young person to monitor their own asthma as best as they can. Next slide, please. So how are we guided on how to manage children's asthma to the best that we can? Well, in September 2021, there was a national bundle of care publicised that talks about how the whole system should be looking after children who have asthma. And that means all organisations, everywhere where a child might touch base. That might be primary care settings, secondary care settings, schools, family hubs, or sports associations. It's really important that somebody takes responsibility for these children in whatever setting they're attending, and that we have leaders. We're encouraged to have a lead in primary care, secondary care, and we're encouraging this highly in schools, that someone has a little bit more responsibility and also understands asthma a little bit more. However, we're encouraging all professionals who have who are manage children or look after children who have asthma to know more about asthma. We want everybody to be aware of environmental impacts. The impacts of having car engines running outside schools or mould and damp within the home is really important. These factors all affect asthma. We want children who have or who have or are showing signs of having asthma to get an accurate and early diagnosis to make sure young people are treated appropriately and early and get their asthma well controlled and prevent these admissions and presentations at hospital. We want children to be on the right treatment. We want children to be on treatment that they can use and treatment that's effective when they become unwell. And also that they're on the minimal dose that they can manage while keeping their asthma symptoms controlled. We want everyone to be aware of what an exacerbation looks like, what symptoms are present and what this means to the child, and also if the exacerbation is serious and needs urgent attention, what actions that everybody should take. We know that there's a percentage of children who have asthma who are classified as having more difficult and severe asthma, and there are services dedicated to these children. We want these children to be acknowledged, and we want these children to be in services as soon as we can possibly get them into services to ensure that their care is at the best standard that we can give them. We want everyone who are looking after children, whether that be healthcare professionals or professionals in an after-school setting or in school settings, to know about asthma and to know and recognise deteriorating asthma, but also know what to do and how to do it and give children the appropriate and the best care. And we're going to talk about this a little bit later on, but there is now training opportunities that we can signpost to you within school that will ensure everyone is kept up to date with the best care for these children. The last facet of this bundle talks about data and digital systems, and these exist in all sorts of organisations. But I think for school particularly, we can think about what does our digital systems or what can they tell us about children within our school? We know that absences are recorded on digital systems, and maybe we could take a look at this and say how many children are being affected within school by their asthma symptoms, how many children are off, and could something be done about this to support these families within school? Next slide, please. So the main types of treatment we've got for asthma controlled, and the main types we've had until very recently have been relief inhalers, and these are the inhalers that you probably see very, very often in school. Relief inhalers are the inhalers that are taken at the time of symptoms, or they may be taken in anticipation of potential triggers like before PE, etc. Just to say that this is becoming less within management. We're not doing this so often now. So we're saying that children who need to have a preventative inhaler before PE, exercise or going out to play may be those children who need to have the preventative medication altering, because if you need relief inhaler every time you do activity, it shows that your background treatment may not be high enough or not be working well enough for these children. We've got preventative inhalers that come in several forms and colours, and we've got lots of those in schools, and I'll go into a poster now and show you lots and lots of different ones. But it's important to know which inhaler does which job. Some children, when I visited schools in the past, have had the wrong inhaler in school, so the preventative inhaler has been there instead of their relief inhaler. What's new, and I'm going to talk a little bit more about that, is combined inhalers. Combined inhalers are those that have maintenance, which are preventer, and relief inhalers in the same inhaler. And we may see these inhalers starting to come into school more often, and I'll explain a little bit how that works within the next few slides. The more severe type or the more difficult forms of asthma may also have different forms of different forms of treatment that they might be taking at home. They might be having oral medication, they might be having nasal sprays, and for the more difficult types of asthma, some children may well be having injections every 2 to 4 weeks in their secondary care hospital settings. Next slide, please. Here you might see some familiar inhalers that you may or may not have seen in school. On the left-hand side are the ones called preventers. These are inhaled corticosteroids. Children should only have these inhalers in general at home, morning and night. On the right-hand side, you can see the ones that you're more familiar with. The blue inhalers, the ones that children respond to quickly when their asthma is exacerbating or getting worse. These are the inhalers that open up the airways, but they don't treat the inflammation in the background. The children may also be taking long-acting blue inhalers. They're commonly green, but now there's several different colours of these inhalers as well. And at the bottom, you can see combination inhalers. Until recently, these are the inhalers that children would have only been taking morning and night, but now there's a new way of taking these inhalers that you may well have already seen in school, but will definitely be seen much more often in the future. Oh, excuse me. Next slide, please. All inhalers that are in aerosol form, or commonly known as meter-dosed inhalers, should be taken in spacers. Spacers are all sorts of shapes and sizes. The most common one you'll see is on the far right-hand side, which you may well have in your school's emergency inhaler kit. And these smaller ones, the orange ones and yellow ones and blue ones, it's a much more common practice for children to have these smaller inhalers now. And the benefit of these is they're much more portable, and the end is universal, so fits all sorts of aerosol inhalers into them. But no child should be in school with an aerosol inhaler without having a spacer. Next slide, please. So how do we know as healthcare professionals what the best management is for children who have asthma? Well, we have guidelines that are published every few years, and we have some new guidelines in November 2024. For the very first time, all of the guidelines in the UK are agreeing with each other on the best practice and management for children who have asthma. And this talks about in primary care practice, in secondary care practice, and the involvement of schools in the best management of children for children who have asthma. Next slide, please. Just to inform you also that we've got some specific local guidelines which refer to children in the region of the North East and North Cumbria. They are associated with guidance for physicians and healthcare practitioners, but just so you're aware, there are some local guidance that we can refer to and to support children both in and out of school. So what are the key messages from the new guidelines? Well, what we do know is there's a specific overuse of blue inhalers and relief inhalers in the North East and North Cumbria. There are certain numbers of children who only have relief inhalers and don't have any preventative treatment. Using a relief inhaler more than 3 days a week demonstrates poor control of asthma. Collecting more than 3 prescriptions a year, there's 200 doses in a blue inhaler, and there's as many as 12 inhalers being collected per year for some children in this region. So it's really important we're aware of that. The relevance to school might be that you might see a child using a blue inhaler really quite commonly within school. They might be using it 2 or 3 days a week. They might be using it more often than that, or they could even be using it daily. If a child is using their blue inhaler daily, it means their background treatment isn't sufficient and they need a review. All children should be having an asthma annual review every year, but we do know there's 8,000 to 10,000 children in the North East and North Cumbria who in the last 18 months haven't had an annual review. The risk of using blue inhaler more often is a risk of a severe asthma attack, because it demonstrates that the preventative inhaler dose isn't high enough or that they're not on a preventative inhaler. Next slide, please. So the answer to this is relief inhalers will no longer be used as treatment alone. The first step of treatment will be a low-dose inhaled corticosteroid inhaler and a reliever as well in the younger children. They will always be used with a spacer when used in an aerosol form, and the frequency of use of this blue inhaler is an indicator of control. So if a child only uses their blue inhaler once to twice a week or less, it's evidence that their asthma is well controlled. If they're using it more often than that, it means that the child needs a review. Next slide, please. So one of the things that has changed in the over 12 age group, it won't be seen in primary school children, is that there's something called air therapy, anti-inflammatory reliever. This is one inhaler that has a steroid in and a relief inhaler. This inhaler is meant to be utilised and used for children with a more milder form of asthma, not for those children who have regular flare-ups of their asthma symptoms. So it might be a child that just on a couple of occasions in the springtime has an exacerbation of their asthma, or on the opposite time of year, just in winter, there's a couple of times a year where a child becomes unwell with their asthma. It's not for those children who have regular symptoms. It might be a step up into treatment, and it may well be a step down. Next slide, please. So MART therapy, we've had some contact with schools already who have said that they've been getting new and different inhalers into school. MART means maintenance and reliever therapy. So now a step up from air therapy would be if a child needed a combined inhaler morning and night, but because it's got a relief inhaler in it as well, they can have an additional 8 doses throughout the day. There is a restriction on how many they can have altogether, but if children have more than 4 doses together and their symptoms aren't relieved, then they need to be seen urgently. But throughout the course of the day, an extra 8 can be given as long as it's spread evenly throughout the day. So that would mean if a child is having a particularly difficult time in winter with their symptoms, they might have had their inhaler twice in the morning, but they might have it mid-morning, they might have it mid-afternoon, but that's fine as long as the child responds well to when they take their extra dose of inhaler. So these are just some examples of the ones you might see commonly come into school. The top one is an aerosol, so it'd still be taken with a small spacer. Some are easy breathe, and the one in the middle, which is white at the bottom and red, is the one that schools have contacted with us about previously. Only till recently, this was just a morning and night dose, but now it can be up to 8 extra doses in the day, but only if a child is prescribed and on MART therapy. All children will have written asthma management plans, and it's important that the parent has explained to school which treatment they're on and that a copy of the management plan is handed into school. Next slide, please. So, okay, the next part of our presentation, I'm going to hand you over to my colleague, Clare Caygill, who's going to talk to you about be asthma-friendly schools and where do we go from here. Thank you, Clare.
Thanks, Carol. Hello, my name's Claire. I'm also a community asthma advisor and I'm a specialist public health nurse for the 5 to 19 service in Stockton. So just following on from what Carol has said, this is one of our really useful regional resources, the Be Asthma Friendly, the Be Asthma website. Here is an example. This actually shows on this page an example of all the different inhalers that may be used. There is actually videos attached to this page. So if you are getting a child coming into school with a new inhaler, it would be useful to watch the video because this would show exactly how the child should be taking the inhaler. The parent should hopefully show you the technique if it is a new inhaler coming into school, but obviously this is also there for support for yourself. So the different spacers and the different inhalers that can be used by children and young people. Next slide, please. And again, you know, Carol has discussed the different types of inhalers. This is our personalised asthma action plans. So again, there's a variety of plans for children on meter-dosed inhalers and also MART action plans for 5 to 11-year-olds and 12 plus. So there is examples of these within the website if your schools would like to have a look. We'll go through these in some details later and discuss some examples of them during the presentation. Next slide, please. So this is an example of a meter-dosed inhaler plan. There is lots of different types out there. So this is one that may be coming into school. In our work across the North East North Cumbria, we are working with GP practices and practices nurses and requesting that these are sent as a copy to school, or parents provide them, or the children and young people may have them. They may have a link on the phone if they're an older young person. Otherwise, you may be able to receive a paper copy into school that would be worth keeping within the child's individual healthcare plan. As you can see, it's got the triggers and what you know the child's triggers may be. It's really clear. It's got the patient's doctor, and it may also have the asthma specialist nurse, whether they're under a practice nurse or a specialist nurse within the hospital setting. This is a leaflet that folds into 3. And then if we just have the next slide, please, Laura. And then this is obviously the other side. So we have our green section when I have no asthma symptoms, our amber section when my asthma is getting worse, and red zone is when I'm having an attack. So you can see how this is really useful for schools because it's individualised to the child. So when the child's green, it means their breathing is good, they have no cough or wheeze, they're sleeping well, they're not missing out on school, and they're able to undertake their normal activities. It then says how many puffs or sucks of the inhaler that the child or young person should have. We then move on to the amber zone, so that they would move on to the amber zone if they've been taking more than 3 doses or sucks. The amber zone is when the asthma is getting worse. So they will be having things like a cough. They may complain the chest feels tight. They may be a little bit out of breath. They'll have used their inhaler, the reliever inhaler, more than normal, and it isn't lasting the 4 hours. The child might be a little bit wheezy. So therefore, what we should do is follow the instructions, and what we recommend is now the regional guidelines is that the child should take no more than 6 puffs. If a child takes 6 puffs and they are still feeling unwell, wheezy, or have a tight chest, we would need to move into the red zone. We can then increase the inhaler up to the 10 puffs, but what we're saying is if a child or young person has needed to take 10 puffs of an inhaler, they need to be seen by a medical professional. Again, in the red zone, this is I am having an attack. So they will be finding it very difficult to breathe. They will be wheezy. They're probably unable to talk in sentences. And actually, they will be quite frightened now. During this stage, well, any of these stages, what we would recommend that the child is never left alone. Somebody should be staying with them to try and keep them calm, talking to them and making sure that they're supported during this time. If the ambulance hasn't arrived within 10 minutes, we recommend that you would recall the ambulance, and you can see the information is on there. The child can still continue to have the inhaler 1 puff at a time. Usually try to take 4 or 5 breaths every 30 seconds. And like we say, if the ambulance hasn't arrived within 10 minutes, we'd recommend that you recall again. Next slide, please. So this is an example of the new MARC plan that Carol discussed. So this is the 5 to 11-year-old plan. Again, you can see it's very similar. It has their asthma nurse, has the doctor. It says what their treatment is. And also, again, we've got our viruses, our triggers, viruses, pollen, and those would be ticked depending on what the child's individual triggers are again. Next slide, please, Laura. And again, it's still a 3-fold leaflet. So the difference with this one, again, is exactly the same. We've got green, no symptoms. This is an inhaler that you suck, you don't take with a spacer. So the child would suck the inhaler to get 1 dose. Again, if they're having no symptoms, it would be they'd have no cough or no wheeze. The sleep wouldn't be disturbed. They'd be able to carry out the normal activities. And again, like Carol's reinforced, if the child's taking 3 or more doses of this or sucks of this, it may mean that they need to have a review with their asthma nurse. If they have taken 3 sucks and it still isn't working, we need to move into our amber zone. So this again is when our asthma is getting worse. So it might be that they are feeling a lot more wheezy, they're feeling breathless, and their symptoms of their asthma are getting worse. What we say with this one is that if they've had 3 sucks in one go, or their total 8 sucks in one day, then we would recommend that you move into the red zone. In the red zone, again, this is I am having an asthma attack. So you can see again there, it's really important. They've had the 3 sucks, they may have even had their 8. Try and sit and keep them nice and calm. Try to take another suck of the reliever. They may be breathing very fast now, they're too breathless to talk. You may even notice some colour changes, and the child or young person again will become quite frightened. So this is where we would need to call 999 and ensure that we're getting our medical support. If the child is taking this inhaler, what we know is that it is much harder if they're struggling to breathe to take this inhaler. If for some reason the child can't take the inhaler, Obviously, schools do still have the emergency blue salbutamol inhaler with the spacer, so schools, can choose obviously to support the child as best they can, because if they're not managing, if they can't take their inhaler, then obviously while you're waiting for the ambulance, you may seek some further advice, or use that inhaler to help relieve them. Next slide, please. So there is a big shift with the NHS, obviously, to look at the environmental impact, and there's certainly the National Bundle of Care has some key deliverables about improving indoor and outdoor pollution. But the best asthma care management is prescribing the right inhaler for the right person. So when an inhaler is prescribed to a young person, the inhaler technique is checked to ensure that they are able to manage that inhaler. The greenest inhaler is the inhaler that should be of choice, but it should be one that the patient can manage and is able to use correctly, so it maintains good asthma care. Next slide, please. So moving forward just to the Be Asthma Friendly Schools, this was an area of work that Carol and I have worked across all the schools with North East North Cumbria. Every school has been invited to take part in the accreditation. At the moment, we've got over 100 schools working through the process, and we have 26 currently accredited. It's free to any school in North East North Cumbria. It comes with free training, and there is also support from Carol and myself to undertake the process. It's to encourage students to feel supported and encouraged to be in an inclusive environment. It supports the staff with the health, safety and well-being of students, and actually it ensures that staff feel much more confident. It ensures that schools are implementing the best practice for asthma management and strategies, and it enables schools to promote their asthma-friendly awareness across the community and increase the confidence. Some parents will see that the school's an asthma friendly school. If they have got a child who has got asthma, they may feel more confident in sending their child there, knowing that the school is able to confidently deal and support their child within the school environment. Next slide, please. So Carol and I have developed a very simple, it's 9-step process. This is just building on all the good practice that you already have in place within schools. There will be some extra bits like the training, but everything else, a lot of the schools have said we actually had that in place, but we didn't maybe have it all together. So we've developed, there's a Be Asthma Friendly Schools policy that has been written by our asthma leadership group with our consultants. This is bit you just print off. The resources are all within the pack. You will print it off, put the lead champion or name who's going to be the identified leader within school, and add it to your policies to ensure that staff are all aware. Some of the schools that are in trusts or academies, what they haven't been able to do is they've had to actually put it as an amendment into their medicines management policy. So they haven't written a new policy, they've used our policy and just added it as an amendment to their policies and made sure that all staff are aware. An asthma register, this can be your medical register, but just as long as those children who do have a diagnosis of asthma are on that register, and that any member of staff has access to that, whether it's cover staff or any teaching staff is aware of which children within which class do have asthma. Emergency kits, you'll all be aware hopefully that schools from 2014 could purchase emergency kits from local pharmacies, just with a letter from the head teacher. There is a copy of the letter in our pack, resource pack. We recommend that secondary schools or large schools have 3 kits, and smaller schools would have 2, just in case one went off site for a trip, then that there is always a kit left within school. And there is a list within our pack of what should be included within that checklist. All medication, so children with asthma, that parents provide the medication and the spacer for that child and young person with the prescribing details. I know it's difficult, but with it on that box, there is the prescribing details that's been prescribed by a medical practitioner that should be provided to schools, so school know exactly what medication the child takes and when they might need it. For children and young people who are maybe transitioning to secondary, if school feel it's appropriate, you'll already have an individual education healthcare plan in place for the child or young person. What we're suggesting is that maybe in year 6, that if you felt, school felt, parents felt it was appropriate, that that child or young person was maybe able to go and take their inhaler and tell the teaching member of staff that they had taken their inhaler. This is to ease with that transition, because they go from being nurtured in primary where their inhalers are kept and they go to the class teacher, to then suddenly moving to secondary and being responsible for carrying it with them every single day. So it's just to support that if schools feel that is appropriate and the young person is able to do that. Moving on to pollution, which obviously we've discussed is in the National Bundle of Care. It's just an awareness within school, and it's 3 bullet points we like here. So you're a smoke-free, vape-free site. You've got a policy in place. You don't have sprays, particularly the secondary schools. You know, young people certainly aren't allowed to use the links and things, because this can really trigger somebody who does struggle with their asthma. Might be that the grass is cut, you know, on an evening, or children aren't sent out to play straight away on freshly cut grass. And again, like emissions, that cars aren't running their engines, or school transport leaving their engines running while they're waiting to collect and pick up the children. I know some of our local schools that we worked with for the pilot, they actually had like an emissions free zone where the cars had to park a little bit of a distance from the school and then walk to collect the children, so that there wasn't emissions running, car engines running just outside the school. Whole school approach. I mean, this is something that schools are already taking on board. You know, do you have a social media page? Do you use the Dojo apps? How do you send information out to parents? Do you invite them in for events? And it's just, again, some way of showing how you're working with the parents community and involving them in your school working day and life. Children and young people ambassadors. We're not asking that you make children asthma ambassadors, but you may already have some groups set up, like playground buddies, school council, prefects. Using some of those children, maybe they might have, at some of the schools have had meetings about medical conditions, and maybe just had some minutes to say we've discussed medical conditions and asthma. Some of the young people, there is resources within the pack where they can put up information around the school as posters, so they may have made a board. Or we've even had some schools go you know, above and beyond, and some of the young people that are maybe in, you know, older, spoken and done an assembly about how it feels to have asthma, what they might need to do, when they might need help, and things to look out for. And we leave that up to the school, however that works best for yourself. And then the main thing is that there is some free online national training that is available to schools. It's a 30 to 40 minute session with some multi-choice questions at the end, and each member of staff would be provided with a certificate. To achieve the accreditation, what we do like is 85% of staff who have direct contact with children and young people. So it might not be that your PE staff or your music staff who come in for an hour a week have to complete that training. It might be that, you know, sometimes there's always a teaching assistant available. Some schools haven't necessarily asked all the dinner staff to complete it, because there is always teaching assistants or teaching staff out on the playground or with the PE teachers. So that obviously what we expect is in the primaries, it's not as difficult. In the secondaries, we know that there's huge numbers of staff, so it is about making sure that if that child walks down a corridor, if the first member of staff can't help them, that the second member of staff would be able to help them, because we've got a number of staff that have completed that national tier training. Next slide, please. So schools would just work through the process. So some schools may have got in touch. We have an email box that we reply to. Some schools have got in touch and said, we think we're ready to be accredited. We've completed the training. Other schools have wanted to talk through the process. That's absolutely fine. You can email the box and we can either have a meeting or a telephone contact to go through the process with you. Other schools might just email with some queries and then email back and say, right, we think we're ready to be accredited. Whichever way works works best for yourselves. What we're saying is we don't want you to be doing lots of extra work. When we come for the visit, it's very informal, and we'll sit down and have a chat and just work through the checklist with yourselves. It might be that some of your information is kept online, so you would just say, right, this is our register online, or other people have paper copies of information. However works for your school, like I say, whatever works best, we'll just come and work through the process with you. And as long as you can evidence that you've completed the checklist, we would be able to then accredit you as a Beat Asthma friendly school. This is an example of the policy. Like I say, it's just ready to print off, and then on the first page you might want to put your school logo on and whoever your lead or champion is for the school. Some schools have one or two, other schools might just have one lead. It's whatever works best for the school. Next slide, please. This is just an example of the checklist. So as you can see, it is just tick lists of all the things that I've gone through, the 9 steps. Just when it comes to the pollution section, we just like 3 bullet points. So it would be, like I said before, you're a vape-free, smoke-free site. Car engines are not running. It might be that your playground's set back off the main road, and you don't allow sprays and plug-ins and candles within the school setting. And it can just be those 3 bullet points. And again, how you involve parents, a couple of bullet points about they're invited in, you share information on social media, and how you involve the children and young people again. And it is just, like I say, a tick list until you come to the pollution and the whole school approach. Next slide, please, Laura. Just moving on from the Beat Asthma friendly schools, I think we started with sort of Beat Asthma friendly skills, and then we've developed and realised that children spend a lot of time, not just at school, but at activities after school, or maybe activities within school. So there is a much simpler version. It doesn't include a policy. There is just an inclusion statement. Again, that there would be just somebody that leads within the sports or activity club. There's a register, so you're aware of who has what medical conditions. Children bring their own inhaler. It's not often that they hand it in, but they maybe bring it so that you know that they've got their inhaler and the spacer with them and what they might need to do. Their action plans parents have discussed with you, because obviously you wouldn't have the individual healthcare plan, but hopefully the child would have the personalised asthma action plan that they may bring a copy of, or at least the parent discuss with you what needs to happen. Looking at pollution again, and we certainly, when we had a Red Card Gymnastics Club achieve accreditation last year, and they really had to consider sprays, the young girls using deodorants and young boys using deodorants within the gymnastics setting. So there was an area moved so that they were set aside so that they weren't in the main gym if they were spraying deodorant, and also to consider the chalk for the bars, because it did make it quite a dusty environment. Also communication, how you communicate with parents, and again there is the training available for the sports and activities. We like 75% of staff trained for the sports and clubs accreditation. Next slide, please. This is just an example of the training. So there is 5 tiers of training. Tier 1, 2 and 3 are free, and this is the national training. Tier 1 is aimed at sort of education staff, social care, housing, sports clubs, leaders, and like I say, it's free. It's 30 to 45 minutes, sort of what is asthma, what's the triggers, what to look out for, how you would treat it, and what to do in an emergency. And then there's a couple of multi-choice, well, maybe 10 multi-choice questions at the end, and you would gain a certificate. This lasts for 2 years, because obviously we have just had some recent updates regarding treatment and changes. So that certificate would last for 2 years. And like I say, it's absolutely free for staff to undertake. We've also tier 2, if people want to do it, that is free. That is more for sort of health visiting, school nursing, public health nurses, and anybody who's got a little bit more interest, because it does go into a little bit more prescribing and treatments. And tier 3 is for your practice nurses, GPs who may be changing treatments for children and young people. Tier 4 and 5 there is a cost for, and that would be for our specialist respiratory nurses and consultants to undertake, and the link's there for that, and we can obviously share that in the chat if people or it's hosted on our Healthier Together. Next slide, please. This is just our regional resources. So we've got our Beat Asthma, Beat Anaphylaxis. Like I said, lots of information on there for parents, carers, children, young people and professionals that you're welcome to look at and use. It's got the videos on, the plans, what to do in an emergency. There's posters, lots and lots of resources. And obviously all our information is hosted on Healthier Together, which obviously doesn't just have asthma, it has lots of long-term conditions and other conditions, and is a really, really useful resource for schools and parents. Next slide, please. I think that's us finished. So just to say that, you know, one timely intervention or advice could actually change the quality and reduce the risk for a child or young person with asthma. Thank you, everybody.
Thank you, Carol and Claire. I'm just going to open up to questions. We've got one question in the chat already. When will the flyer for children's asthma plans be implemented with the GPs, please, so that schools can use this as evidence for diagnosis? We have had children recently come to school with inhalers, but no diagnosis info. Don't know who wants to answer that one.
So does that does the flyer mean the actual management plan?
I'm thinking it was Brendan who's asked. Yes.
Yeah, great. So we are working very closely with GPs and all practices in the North East and North Cumbria. The standard for children is every child should have a written asthma management plan, and that plan is written by the physician or the practice nurse or the specialist nurse who is looking after that child. In secondary care settings, almost 100% of children have asthma management plans, so they should be bringing them to school. Primary care, certainly the numbers of children with management plans are increasing, but we are aware until very recently there was probably only 30 to 40% of children had a written management plan. So as a school, please ask parents, do you have one? They sometimes don't think they need to come to school. And if they don't have one, the families can ask their practice nurse for a written management plan, because they should have one for the family at home and, you know, for the child at home anyway. Hope that answers your question. You'll definitely be seeing more management plans being brought to school in the near future.
Dr. Ramphul, do you want to come in?
Thank you. So I'm Neelmarnee Ramphul. I'm a consultant paediatrician at the QE and in Gateshead, and also pediatric clinical lead with the Child Health and Wellbeing Network for asthma. Thank you to everyone who's attended today, and thank you to Laura, Carol and Claire for the fantastic overview that they've given in a short space of time. I also wanted to add from what Carol has said, as you know, you will see more and more plans, but there's also a lot of information on the Healthier Together website. And you can, for example, send a standard letter that you can access from the Healthier Together website that can ask the families to bring in their personalised asthma action plan. And equally, if you are seeing these children, particularly on the playground, and they've got symptoms, you know, there are standard letters that have been developed from the team that are on the Healthier Together website that you can send out to say, you know, you've noticed that they're having more symptoms. Encourage them to have an asthma review. They may need to see their GPs. So maybe if we can send that link as well, Laura, in with the slides, because that will just, again, reinforce the message that their treatment needs to be reviewed, and what you've noticed, and that, you know, you're suggesting that they probably seek an earlier review. The thing about the asthma annual reviews is it is an invitation. It is a bit like screening. So they get an invitation to attend. And we know that in the region, sadly, quite a few people don't take up the invite, or sometimes people wait until they get the invitation to attend. So again, if you're noticing symptoms, then it's important to kind of be able to highlight that they might need a review earlier than planned.
Thank you. I think the questions very much are coming back in about we have children coming into school with no spacer and no plan. Can we ask that parents go to the GP to get this?
Yes, I've just put in the answer. Yes, you absolutely can as a school. You can challenge that the child doesn't have a spacer or a plan. And as Neelmarnee says, there are templates on Healthier Together that you can print off, put the child's name on and send home to school, send home from school. I think there's we shouldn't be seeing children in our community now who have an aerosol type spacer, an aerosol type inhaler and no spacer. It's standard practice that they need a spacer, and also that they should be having a management plan. So when working with schools, we found one of the things that the schools did do is send letters home and say, we've had recent training and we've noticed that your child does not have a spacer in school. Please seek advice from your practice asthma nurse. And that has been corrected in a lot of cases. Right, so in terms of, there's a question that says, will the surgeries prescribe sufficient spaces to stay in school? What we're asking primary care settings to do at the moment, which are GPs, is to ensure that the child has two, one for home and one for school. If not, we just ask the parents to repeat the prescription in a few weeks' time. Primary care settings are aware that the child does need a repeat of their spacer at least once, because we do need a spare one. And in some cases, when we've got split families, they need more than two because there's another parent to be visited at the weekend. So sometimes this is the expectation at the beginning of a prescription, that there will be more spacers asked for, and sometimes occasionally more relief inhalers asked for this purpose, one for home and one for school.
I think I was just going to say, sorry, and Beth, our colleague, is a practitioner. She's actually working with pharmacies, GPs across the North Cumbria, and encouraging, personalised asthma action plans and spacers to be provided for school.
Okay, there's a question from Kirsty who's asking, what age do they need a spacer? 2, please. In actual fact, if you have an aerosol inhaler, you have a spacer at any age. The only inhalers that don't have spacers are the dry powder devices. So that's sometimes considered at senior school age. And when I showed you the picture of the poster of all the different inhalers that we have, some are gases and some are not. They're called dry powder devices. It might be when they get to senior school age, they get assessed in their GP practice for suitability for a dry powder device. But it does depend on the severity of their asthma as to whether they can have a dry powder device. But most importantly, at home there is still there is still a spacer and an aerosol, because occasionally, and depending on the severity of the presenting symptoms, the dry powder devices aren't as effective for some children. So it might be that a child has a dry powder device in school, but in an exacerbation or becomes unwell with their asthma, that they may well need to use a spacer. So you might have a child walking around with a dry powder device, but they might have a spare spacer and aerosol inhaler in school. So any child of school age should have a spacer if they've got an aerosol inhaler.
And I think I would just stress that point that Carol's made very much, because, when you get older children, often the families will say, oh, they're really good at using the spacer directly in the mouth. And no matter how much they tell you that, or how much they feel they're really good at using it directly in the mouth, if it is an aerosol or an MDI inhaler, they're not going to get much of the medication in the lungs. And we keep reiterating as well that using it directly without a spacer, if you've got an inhaler that's designed to be used via a spacer, they're going to definitely get less than 20% of their medication. So if they're telling you that they're using it directly in their mouth and it works, well, it isn't working. If they're using it directly in their mouth and they are well and they're not having symptoms, then they again need a review, because it may be that they actually don't need an inhaler. And if they're using it directly in their mouth and they're having to use it very frequently, it's because they are not using the spacer.
There's just a final question from Claire. Claire's asked, if we have a spare inhaler in school, do we need a spare MART as well? Or is the salbutamol inhalers enough? So what I am suggesting, as we've changed over to these MART regimes, that parents request a second MART inhaler from their GP. Because what we are saying is, at the very beginning of that management plan, when the child is showing just initial symptoms of needing their inhaler, if their own isn't with them, then there is no need to use a blue inhaler. They should just have a spare MART in school. So most of my patients from secondary care, we're trying to prescribe 2. And if not, we're prescribing 1, and we're asking them to request a second one from the GP within a week, so that there is a spare one in school. For children on MART regime, we're trying not to get them to use a blue inhaler unless they've got more difficult asthma. So if a child is under a secondary care setting and we have swapped some children with more difficult asthma to MART regimes, we do say to the parent that in the scenario where their MART inhaler doesn't appear to be working effectively, they can change to blue inhaler, but this is not the run-of-the-mill child. In general, children who are under the care of their primary care physician, their GP, and they're changed to MART, they should only need a MART inhaler.
Thank you very much, Carol. I'm going to stop there with questions, and if you have got any further, you can send them straight to the email in the chat, and the team, what we'll do is some of the questions that have already been asked, we'll send a bit of a Q&A answers to them so that you've got them in that summary as well. Is that okay for everybody? Because I'm just conscious of time. We are slightly running over. Thank you very much for attending this afternoon. We will hopefully get the recording up on the Healthier Together website as well within the next week or so. But we will share the slides this afternoon, and I will share the links to the letters and the Beat Asthma Friendly Schools information as well on the Healthier Together website with instructions of how to access that. Okay, thank you very much for your time.
Thank you, everyone.
Thank you.